Okay. Today we'll discuss. Am I audible? Hello.
Yes, sir.
Okay. Today we'll discuss about general physical examination in neurology. Samir, you move the slides. Okay, first we'll come to blood pressure. It is very important, as all of you know, in emergencies or in OPD practice. Whenever a patient comes with any neurological illness or any diseases, check the blood pressure always in both the arms. Because in case of like extracranial vascular occlusion like Takayasu arteritis or subclavian stenosis, peripheral vascular diseases, these will indirectly indicate the future outcome in the cerebrovascular accidents or any etiology of the cerebrovascular accident. Always check bilateral upper limb and lower limb blood pressures. Significant asymmetry, that is more than 10 mm of Hg in both the hands comparatively, that indirectly indicate the extracranial occlusive diseases. And second point is we need to check the orthostatic hypotension. Anybody knows what is the orthostatic hypotension? Can anybody define?
More than 20 millimeters of drop in systolic blood pressure on standing.
And diastolic?
10, sir, 10 millimeters.
Okay. Good. How will you check orthostatic hypotension?
Sir, we have to make the patient stand for 3 minutes and then check, sir.
Okay. Then initially you have to check in a supine position after resting around 5 to 10 minutes. Both check blood pressure in supine, systolic, diastolic, and pulse rate also. Okay, and tell the patient to immediately stand without any supporting. You have to tell the patient to like sit. You have to tell the patient to stand apart from the bed. Immediately you have to check. Then after that you can check at 1 minute, 3 minutes, and 5 minutes. And one more entity is there, delayed orthostatic hypotension. Sometimes even after 10 minutes of standing, patient might have orthostatic hypotension. Okay, if you are suspecting strongly orthostatic hypotension, better you check at 10 minutes also. Okay, this will help you to diagnose the various neurological condition. Most commonly, as all of you know, diabetic neuropathy due to and one more entity, multiple system atrophy C, multiple system atrophy P. These also predominantly will present with autonomic dysfunction as a part of like orthostatic hypotension. And you need to inquire about the drugs like beta blockers and calcium channel blockers sometimes causes orthostatic hypotension. By stopping these drugs, you can make the patient to completely relieve from the orthostatic hypotension. Next slide. As all of you know, Cushing reflex, it is the sign of the raised intracranial pressure. This contains hypertension, bradycardia, and irregular respiration. First part is hypertension. Whenever patient presented with emergency in a altered sensorium with hypertension, do think of raised ICP also. Not only like accelerated hypertension or hypertensive emergency, kindly think about the Cushing reflex also. It is the earliest sign. Like in triad, hypertension will come the first, then bradycardia, then irregular respiration. Okay. Increased blood pressure due to stroke is often due to peripheral attempts to compensate for the cerebral ischemia. It resolves without treatment. In severe, like if a patient comes with severe hypotension, it is rarely neurological causes. You have to rule out if a patient in an emergency comes with severe hypotension, don't think about neurological cause as a first cause. Rule out the cardiac, septic, and hypovolemic shock. Okay. Next. Second one is pulse. As all of you know, whenever you are defining the pulse, you need to write about rate, rhythm, delay, character, all those things to be mentioned. It is helpful in various conditions that are indirectly indicate the etiology for the current conditions. First, you need to define the rate, like whether a patient is having bradycardia or tachycardia, bradyarrhythmias or tachyarrhythmias. Because all these brady and tachyarrhythmias which causes cerebral hypoperfusion that will lead to syncope or seizures or any stroke-like episodes. In raised ICP, it will cause bradycardia. Whenever defining the pulse, you need to characterize the whether it is bounding pulse or any slow pulse. Bounding pulse, all of you know that is an aortic regurgitation, hyperthyroidism, and in small slow pulse in aortic stenosis. Because these aortic regurgitation and hyperthyroidism associated with various neurological dysfunctions, and aortic stenosis also associated with syncope, seizures, and these patient might come with the seizure-like episode, might come with the episodes of syncopal-like attack. So you need to examine the pulse and detailed cardiac examination also. And by detecting the irregular rhythm in case of atrial fibrillation or atrial flutter, you can identify the etiology for the stroke, and you can manage the patient with anticoagulants, so that it would be a better preventive aspect. Whenever you are giving the antiplatelet therapy for the regular stroke patient, if patient is having atrial fibrillation, you need to treat with the anticoagulation. That will change the future management of the patient. And you need to see for brady and tachyarrhythmias, as I told earlier. Next slide. And during as routinely the respiratory pattern, respiratory rate, rhythm, depth, these should be mentioned in neurological cases also, not only in respiratory cases. All these abnormalities, chain stroke breathing, Biot's breathing, Kussmaul breathings, you have to mention. Chain stroke, it is characterized by apnea or hyperapnea episodes. Biot's is mainly ataxic type of breathing. Kussmaul's, diabetic ketoacidosis, all those things patient will be having Kussmaul type of breathing. These are the later manifestation of the raised ICP. Chain stroke breathing is the late manifestation of raised ICP. So by determining these respiratory pattern, you can identify the Cushing reflexes. And whenever you are seeing the patient, if patient having severe respiratory distress with using the accessory muscles, don't think only cardiac or respiratory causes. If you ruled out your cardiac or respiratory causes, still patient is having this kind of accessory muscle activation, kindly rule out neuromuscular junction disorders like myasthenia gravis, muscle disorders like myositis, GB syndrome, and motor neuron diseases or should be kept in the mind. When your patient present with respiratory failure, especially type 2 respiratory failure, you need to rule out these causes also. Next slide. And smell of the breath. Again, acetone-like smell mainly seen in diabetic ketoacidosis, because diabetic ketoacidosis, again, it is hyperosmolar status that will also causes coma, seizures, raised ICT. Patient might come in a comatose status. You have to see that the smell and sugars, osmolarity, ABC, all those things to be seen. And in case of ethanol intoxication, that smell will also helps you to diagnose the ethanol intoxication. We can treat accordingly. And fetor hepaticus or uriniferous smell usually seen in uremia. Uremia, again, it will causes uremic encephalopathy, uremic seizures, uremic myocarditis, or uremic pericarditis. And in garlic order, arsenic poison, it is characteristic. Arsenic mainly it causes GB syndrome, predominantly axonal variety, and it may present with acute diarrheal disease-like symptoms. And last one is carbon monoxide poisoning, that will appear like household gases, as all of you know, that will cause cerebral hypoxia, hypoxic ischemic encephalopathies, and seizures also. So identifying the smell, you can identify the etiological diagnosis for the coma or any neurological illnesses. Temperature, okay. Hypothermia not always means infection, because other conditions like inflammatory conditions, neoplasms, anticholinergic drugs, subarachnoid hemorrhages, hypothalamic lesions, heat stroke, hyperthyroidism, malignant hyperthermia do also causes hyperthermia. Not like patient is having fever or raised temperature, not always means infection. These all the causes should be ruled out. And hypothermia, second one, like cold exposure, sepsis, shock, these are also causes hypothermia. And other reversible causes like myxedema, ponema, vernix encephalopathy, barbiturate intoxication, and hypothalamic lesions, hypoglycemia. Patient might present with emergency. Patient will present with the emergency with the complaint. By identifying the temperature, you can make out the differential diagnosis. And general aphasia, if patient is having fever, pain, distress, any evidence of weight loss, any abnormal posturing like dystonias, and any unusual mannerism like bizarre activities, restlessness, these all also indicates other systemic diseases associated with the neurological illnesses. Weight loss in neurological illnesses, weight loss or chronic malnutrition that indirectly indicate hyperthyroidism, Alzheimer's, like late degenerative diseases, end stage diseases of the degenerative diseases, Whipple's disease, malabsorption syndromes like associated celiac diseases, or GI amyloidosis. Patient will have neurological symptoms also, and systemic symptoms like weight loss and malnutrition. If patient is having abnormal fat distribution, abnormal hair distribution, and decrease like low sexual secondary characteristic, These also indirectly indicate endocrinopathies, because pituitary and hypothalamus that do regulate the endocrine gland secretion. So whenever the lesion that are present in the hypothalamus or pituitary, that do also causes these kind of symptoms. Next slide. Again, general appearance, you need to rule out gigantism, dwarfism, any gross deformities, amputations, contractures, or any disproportion in the body parts. Like in gigantism, dwarfism, again it is endocrinopathies. Amputations and contractions, peripheral vascular diseases, or myopathies like early EMDs that do also causes contractures. And disproportion body parts mainly seen in collagen vascular diseases. By gross looking the patient from head to toe, you can make out these differentials. So after that, we can go ahead with the investigation to identify. Okay, next slide. Abnormal postures. You all of you know spastic hemiparesis, that circumduction gait. Due to cortical spinal tract in upper limb, predominantly it will causes abduction, extension, and lower limb it will causes flexion and adduction. Due to the lesion that is involving the corticospinal tract, that will causes abnormal flexion deformities in the flexion and adduction deformities in the upper limb, and extension deformities, abduction deformities in the lower limb. That will classically causes circumduction gait and inward rotated upper hand. As all of you know, this is the picture that is depicting the left hemiparesis. Patient is having adducted, internally rotated, flexed upper limb and extended, externally rotated lower limb. Next. Again, other posture, like in Parkinson disease, all of you know, and all of you seen these kind of patient. Flexion of the neck, trunk, elbows, wrist and knees, stooping forward posture, rigidity, mask-like faces, slowness of the movements, and tremors that indicates the Parkinsonism. And in myopathies, due to involvement of paraspinal muscle, patient will be having protruded abdomen and waddling gait and hypertrophy of calf muscles. By seeing these, you can make out patient will be suffering from the myopathy. So according to that, we can evaluate the patient. In peripheral nerve diseases, patient will like wrist drop, foot drop, claw hand, pes cavus deformities. These will also help to identify the causes. As typical Parkinson's disease, patient will be having master face, forward tilt tongue, reduced arm swing, hand tremors, slightly flexed knees, shuffling gait, leg tremors, flexed elbows, back rigidity, and stooped forward features. These all the things indirectly indicate the Parkinson's symptoms. This is again lordotic gait in myopathy. Next. This is a pes cavus due to the enlargement of medial longitudinal arch, because due to the insult to the nerves or any muscles that are involving the deep muscle, small muscles of the foot involvement, this will causes increased height of the medial longitudinal arch. This is called pes cavus. This is associated with hereditary sensory motor neuropathy, congenital myopathies, congenital myasthenia gravis. You can identify by like painting or any if you take any ink and put on the foot in the sole aspect and tell the patient to walk. You can see in a flat foot, it is entire foot will be printing like this. In case of high arch foot, only some amount like lateral aspect will touch the ground, that will make this kind of appearance. In normal, around 40 to 50% of foot will be grounded. So by making this, you can rule out the pes cavus deformity. That will also help in the diagnosis of various hereditary conditions that are affecting the nerve muscles. And head. You have to examine the head. You have to comment about the shape of the head, symmetry, size, and any premature closure of the cranial suture. These are predominantly will be helpful in the pediatric age group. Okay, next. Plagiocephaly, it is the abnormal fusion of the coronal sutures that will causes the flattening of the forehead and brow on the affected side, with the forehead tending to be excessively prominent on the opposite side. Next slide. This is the coronal suture. Due to early closure of this coronal suture, these kind of defect will come, because these craniostenosis most of the time associated with raised ICP, multiple cranial nerve palsies, and syndromes like Crouzon syndrome. So by identifying these craniostenosis, you can narrow down the differential diagnosis part. Next. One more is trigonocephaly. As all of you know, these metopic sutures will close by 18 months, but earlier closure of this metopic suture will causes trigone-like. Anterior spectra of the skull looks like trigone-like appearance. This leads to the prominent ridge in the forehead. And one more is like sagittal suture. If closing up the sagittal lines earlier in earlier part of the life, that will causes long and narrow skull. This is called scapucephaly. As I told earlier, it will causes increased ICP and multiple cranial nerve palsy, and associated syndromes like Clausen's, Appert's, and Carpenter syndromes commonly associated with this kind of craniosynostosis. Head. Again, you can comment on hydrocephaly, macrocephaly, microcephaly, asymmetries on the scalp, and disproportion between the facial and cerebral portions, scars, or any signs of recent trauma helps you to narrow down the differential diagnosis. Again, in the face, you need to see the dilated vessels, telangiectasias, port vein angiomas on the scalp. And again, you can see on the mastoid, that is battle sign, as all of you know, the ecchymotic changes that appear in the mastoid bone, that is called mastoid battle sign, usually seen in the middle cranial fossa fractures. And around the orbital rim, that is called raccoon side, it is seen in the frontal basilar skull fractures. This is the raccoon sign. This is the battle sign. Next. Palpation, percussion, auscultation not only confined to the respiratory and cardiovascular system. Even you can examine these kind of palpation, percussions, and auscultation neurology also. Few indications are there. Palpation, by doing the palpation in the skull, you can make out any old trauma or any burr hole or any craniotomy defects, tenderness on the scalp, or any old scar. You can make out by palpation. And by palpating the sutures line, you can make out suture lines or any fontanelle, you can make out raised ICP, particularly in pediatric age group. Meningoceles, encephaloceles also causes skull defects. Tumors on the scalp, especially cylindriomas or any dermoid cyst in the midline, you can make out the diagnosis. Palpable masses involving the scalp or skull may be sometimes metastatic carcinoma, lymphomas, leukemias do metastasize to scalp. Lymphomas and dermoid cyst and multiple myelomas also causes palpable mass on the skull. Or histiocytosis do also causes these kind of palpable masses the skull. By palpating these structures, you can narrow down your differential diagnosis. And turban tumor, that is cylindrioma, as all of you know. Next slide. Neurofibromas also you can palpate, localized swelling and osteomyelitis, that frontal bone involvement most commonly seen in tuberculosis, that is also called the parts Papet tumor. By palpating these structures, you can make out the diagnosis. And bony lesions like exostosis, meningiomas, bony lesions that also indicates the meningiomas. And by palpating the superficial temporal artery in a giant cell arteritis, you can diagnose the giant cell arteritis. Elderly male presented with the head, elderly male or female presented with the threatening headache, with tenderness on the temporal arteries and absence of pulsation, that will help you to diagnose the GCS. This is parts of tumor, that is frontal lobe, that is due to the involvement of frontal sinuses and frontal bone in the tubercular, secondary to tubercular infections. Next one, percussion. There are few indications for percussion of the skull in the neurology. In the tumor site or subdural hemorrhoma, that usually causes dullness node. In tympanic percussion noted in the hydrocephalus and raised ICP in the pediatric age group, that is called McEwan sign or cracked pod sign. The tympanic percussion and dull percussion, these are the few diseases like tumor subdural causes dullness, raised ICP in pediatric age group that causes tympanic note. Next, auscultation, you can auscultate for the bruit over the temporal regions or on the skull or eyeballs or on the mastoid. Cephalic bruits that do occurs in angiomas, aneurysm, AV malformations, neoplasms that are compressing the large arteries, and presence of atherosclerotic plaques that partially occluding the cerebral or carotid arteries causes bruits. As all of you know, the auscultation of bruits commonly you see in renal artery stenosis in young hypertension, or any stroke patient, you need to see for carotid artery bruits also. Ocular bruits usually seen in intracranial cerebrovascular diseases, that sometimes transmit to mastoid also. You can put steth on mastoid to see for this kind of bruise. And arteriovenous malformation that will usually worsen on compressing the carotid artery. You can auscultate bruise on the like eyeball. You can put stethoscope on the eyeball and you can auscultate. You can heard the bruise in case of AV malformation, and particularly carotidocavernous fistula do also causes this kind of ocular bruise. And murmurs from the heart that will transmit it to the large vessel that can also be make up. Facial expression, this is very important. By seeing the face only, you can diagnose the most of the conditions like acromegaly, myxedema, hyperthyroidism, Down syndrome, mucopolysaccharidosis. This is rhizus sardonicus is in tetanus due to the due to the involvement of the facial muscles due to the tetanus toxin. This is the acromegaly phase, classical. This is hypothyroidism, myxedema phases. Mask-like faces, as all of you know, seen in Parkinson's. Can anybody guess what is this?
Wilson's disease.
Features, can you enumerate? What are the features? Like what are the picture representing here? This one face. This is called evacuous smile. This patient is having like bilateral upper limb dystonia. This is KF ring. This is all of you know face of giant panda. Due to the sparing of red nucleus, this midbrain appears like giant panda. And basal ganglia T2 hyperintense signals. Okay, by seeing the face, dystonia, KF ring, you can make out the diagnosis of Wilson's disease. Next. This is Procerus sign due to the involvement of overcontraction, that is focal dystonia that is involving the muscles of facial expression, classically seen in progressive supranuclear palsy. This is called Procerus sign, also called omega sign also they will call. This appearance looks like omega. Next. Myotonic dystrophy. Can anyone describe this? This one, classical. First pictures.
Absence of wrinkles.
Good. Next. Bald hair, temporal hollowness, bilateral ptosis, orbicularis oris muscle weakness, and short, that is small neck. In pediatric age group, predominantly it will involve the oral muscle that is called inverted V-shape appearance of the orbicularis oris. This is classical of myotonic dystrophy. There are two spectrum, like type 1, type 2 myotonic dystrophies are there, and age of onset would be different. In pediatric age group also myotonic dystrophies do occur. This is elder, this is I think 40 to 50 years, looks like that. Okay, next slide. These are very important. As a physician, you should know ophthalmological examination. At least you need to rule out papilledema grades, diabetic changes, hypertensive changes in the retina. These you should be knowing these things, because in emergency, if patient comes with headache, vomiting, most of the time, like imaging part, it would be difficult in government setup. Better if you seeing the fundus, if patient is having papilledema, means you should you can plan accordingly. So ophthalmological examination, at least you should be knowing how to do fundus examination to rule out papilledema, diabetic changes, and hypertensive changes. Next. In bilateral exophthalmosis due to thyroid eye diseases, in carotid cavernous fistula, patient will be having pulsatile mass on the pulsatile mass in the orbital cavity. Meningocele by palpation or by looking also you can make out the meningocele or encephalocele. And corneal clouding that is characteristically seen in mucopolysaccharidosis. By seeing these on inspection, you can make out the diagnosis directly. Brush filled spots seen in the Down syndrome, least nodules in the neurofibromatosis, keratoconjunctival Sicca-Zagran syndrome, amyloid deposition in the conjunctiva, that is amyloid neuropathies, herpes zoster ophthalmicus, cap ring in Wilson's disease. By seeing this, you can make out like a patient presented with mental retardation. By seeing the brush pigment, you can make out the Down syndrome. A patient presented with like schwannomas, hearing loss, or any peripheral neuropathies. If you see the Lish nodules in the slit lamp, you can make out the diagnosis. By seeing the like conjunctiva or conjunctiva or sclera, you can make out any Zika symptom. By doing the scar masters, you can make out Sjogren's syndrome. Amyloid deposition in the conjunctiva, usually it will be done by the ophthalmologist. Better to be seen in the slit lamp. Amyloid deposition, if you demonstrate, you can rule out all primary and secondary amyloid disease, deposition disease also, you can make the diagnosis. Seeing the herpes zoster lesion, you can predict the future involvement of other cranial nerves or any meningitis, encephalitis, or radiculopathies. All those things can be ruled out by seeing these lesions. KF-ring, all of you know. Okay, next slide. Hypertelorism. Okay. It means the presence of wide-spaced eye. This is diagnosed when the inner canthal distance, this medial canthal, this one is called inner canthal distance. First, you make the interpupillary distance from this pupil, you measure the distance, make it up. Say, for example, the distance between this pupil and this pupil is 6 centimeter. Half up will be 3 centimeter. If the distance between the inner canthal distance, if it is more than 3 centimeter, you can label as hypertelorism. Okay, first you measure interpupillary distance, make it 50%. Then later you measure the intercanthal distance. Okay. If intercanthal distance more than the 50% of interpupillary distance, you can label it as hypertelorism. This can be seen in multiple syndromic like craniostenosis, all those things you can see. Okay. Next. All of you know that bilateral or unilateral exophthalmosis with staring look and various eye signs you might be knowing. These will help you to diagnose the hyperthyroidism. Next. Okay, next one is carotidocavernous fistula. It results from abnormal communication between the arteries and venous system that is involving the cavernous sinus in the skull. It is a type of AV fistula. Next. This is encephalocele, midline defect that will cause us to bulging out the brain tissue outside the skull. Next. This is the corneal clouding characteristically seen in mucopolysaccharidosis. Next, this is the KF ring, brownish color ring due to the deposition of the copper in the basement membrane. Bare eyes also you can make out. Slip lamp examination would be better option. Next, these are the brush filled spots characteristically seen in Down syndrome. Next, these are the Lish nodules seen in the neurofibromatosis. Okay, let us come to the ears. Examination of the ears is particularly important. A patient presented with complaints of hearing loss or vertigo. Examination of ear canal also important. In case of, you can make out the jugular tumor, and patient will be having jugular paramena syndrome, that is lower cranial nerve palsy. And you can make out also you can make out the vesicle of the vesicles due to the herpes zoster by examining the ear canal. And you can rule out the cholesteatoma. Sometimes cholesteatoma also mimics like lower cranial nerve palsy. It extends from the mastoid to the brainstem. CSF otorrhea due to the trauma and basal bone fracture. Patient will have like blood color CSF tinged blood ear discharge. This patient will more prone for pyogenic meningitis in future, and patient will be having facial palsies along with this CSF otorrhea. Hemorrhages in the middle ear that will cause bulged tympanic membrane, characteristically seen in basilar skull fracture. So whenever doing examination, you do examine ears also. By putting a scope or a pen touch, you can make out the tympanic membrane or any vesicles or any blood tinged areas in the ear. Etzelberger sign. This is seen in acoustic neuroma due to the involvement of the 7th cranial nerve. This is very difficult to examine as a theory aspect. There is early involvement of sensory fiber that is involving the 7th nerve that will cause hypoesthesia in the posterior meatal wall. This is the earliest sign in the acoustic neuron. By examining this, you can make out the diagnosis or involvement of the seventh cranial nerve. Next, nose. This is also important. Perforation of the nasal septum characteristically seen in cocaine abuse, and saddle nose deformity is the early sign of congenital spillis, leprosy, or venous granulomatosis. And involvement of the dangerous areas of face, as all of you know, that will leads to cavernous sinus thrombosis or pyogenic meningitis. You examine the dangerous area of face, you can make out the diagnosis. And in cribriform plate fracture, that will due to the trauma, that will cause a CS of rhinorrhea. These patients will also have potential chances of having the pyogenic meningitis. By seeing this, you can take the precaution by giving the neurosurgery reference. If you repair this cribriform fracture, you can prevent the patient from the pyogenic meningitis in future. Next, tongue and oral cavity. That is the triple furrowed tongue in myasthenia gravis due to the selective atrophy of the tongue muscles characteristically seen in myasthenia gravis. You can seeing by triple furrowing can make out the diagnosis of myasthenia gravis. And multiple fissures in the trunk that is seen in the Melkersson-Rosenthal syndrome. What is the Melkersson-Rosenthal syndrome? Any other symptoms of this syndrome? Anybody can tell? Along with these tongue features. Patient will be having recurrent facial nerve paralysis. And macroglassia. How will you define macroglassia? Anybody? Hello. One ನಿಮಿಷ ಕಿರಣ್ ನಾನು ಇದು ಕ್ಲಾಸ್ ಅಲ್ಲಿ ಇದೀನಿ ಆಮೇಲೆ ಮಾಡ್ತೀನಿ. Can anybody define macroglassia? If the lateral border of the tongue touching the angle of the mouth bilaterally, it will called macroglassia. It is characteristically seen in amyloid myxedema and Down syndrome. And other findings include xerostomia and Sjogren syndrome, lead lines along the gums seen in lead toxicity, trismus in tetanus, or any involvement of the muscles of mastication. That is in polymyositis also, patient will have trismus. Mucosal ulceration characteristically seen in Behcet syndrome. And gnashed teeth is the earliest sign of the congenital syphilis. That is also called Hutchison teeth. But seeing the tongue and oral cavity also can make out the diagnosis. Next. Neck, you need to see for adenopathy, thyroid masses or enlargement, deformities of the neck, or any tenderness in the neck region, rigidity, tilting, or any meningeal signs, postural changes, counter, pain on movement. These are very important because adenopathy is all of you know that will associate with obstructive airway diseases, obstructive sleep apneas, headaches, stroke, like episode. Thyroid masses, again hypo or hyperthyroidism, again it will cause us neurological manifestation. By seeing the neck tenderness or neck restriction movement, you can make out the cervical spondylosis, or if any pain during flexion of the neck, that will indicate the meningeal irritations. So you can work up according to the symptoms and signs. This one I will say. Meningeal irritation can cause nuchal rigidity, head retraction, and opisthotonous posturing. Neck movement may be also restricted with cervical spondylitis. So to differentiate, if elderly patient with cervical spondylosis come to the emergency with symptoms of meningitis, it is very difficult to rule out because even cervical spondylosis also causes limitation of neck movement. So by doing this maneuver, usually meningeal irritation that will cause primary limitation in neck flexion only. But in spondylosis, limitation would be global, like either flexion, extension, rotation. All kind of movements will be restricted in case of cervical spondylitis. But in meningeal irritation, only neck flexion will be affected. Next. In the Klippel-Pill syndrome, syringomelia, platybasia, neck will be short, low hairline will be there. There will be restriction of neck movement also. Next. You need to examine for the deformities like limb deformities, contractures, edema, color changes, Any variation from the normal size or shape of the hand, feet, or digit, joint changes, contractures, pain on limitation, localized tenderness, wasting, clubbed fingers, ulcerations also important. And edema, that is CCF cardiomyopathy. These CCF patients sometimes present as cortical vein thrombosis or cerebral hypoxia or cardioembolic stroke. So edema and cardiac failure features also to be noted. Arthropathy or arthritis is character sign of connective tissue disorders, sarcoidosis or Whipple disease. These indirectly associated with neurological illnesses. Painless arthropathy, as all of you know, in diabetes or any involvement of large fiber involvement neuropathies, this is called Charcot joint that occurs whenever joint is differentiated due to the neuropathy that will cause painless enlargement of the joints. This is characteristically seen in the syringomyelia. Initially, it will occur in the shoulder joint. Palmar erythema, all of you know, in chronic alcohol abuse or chronic liver cell failure, not the liver cell failure sign. Disease of the nervous system that are associated with the connective tissue disorders that will causes the abnormal body proportion, syndactyly, polydactyly, and arachnodactyly also. And nerve thickening, this is very important. Whenever you are taking a neuropathy cases, kindly do examine nerves like a supraorbital nerve. There's marked here. This is supraorbital nerve, greater auricular nerve, cervical nerve, ulnar, median nerve, radial cutaneous nerve, common peroneal nerve, and posterior tibial nerve. All these nerves to be examined because nerve thickening will also give you differential diagnosis. Common diseases that are associated with the nerve thickening are hereditary motor neuropathies, CIDPs, amyloidosis, refsums. Next slide. Leprosy, most commonly nerve thickening. You have to rule out in Indian setting, leprosy to be ruled out whenever patient is having the nerve thickening. Other causes I have told. One more is neurofibromatosis, neuromas, nerve tumors, amyloidosis. CIDP also one of the differential diagnosis for enlarged peripheral nerves. Skin. Again, you need to see for spider angiomas in CLD, erythema migrans in Lyme's disease, purpura petecae in TTP, meningococcemia, and RMSF fever. Livedo reticularis is seen in Apla syndrome and cryoglobulinemia. Next, if you are taking the case of neuropathy, when you are presenting, you need to examine any features of purpura or livedo reticularis that is seen in vasculitic neuropathies and cryoglobulinemia. In Fabry's disease, patient will be having angiokeratoma. This is characteristically seen in periumbilical regions. Skin hypopigmentation is seen in leprosy. Skin hyperpigmentation is seen in Poem syndrome. Bullous lesions are seen in porphyrias. Ichthyosis in Repsom's disease. Measlines in arsenic poisoning. Alopecia characteristically seen in thallium poisoning. Curly hairs are seen in giant axonal neuropathies. These to be mentioned in the general physical examination or in a head-to-toe examination. You should comment regarding this whenever you are taking the case of neuropathy. Next, in case of ataxia, you need to mention the stature, any telangiectasias, cataract, cave rings, lipomas, organomegalies, hypogonadism, myopathy, diabetes, foot deformities, skin pigmentations, sinus infections, tendon xanthomas, all these things to be seen whenever you are taking the patient ataxia case. Okay, next slide. If you are taking the myopathy case, you have to see for the cognition and any symptoms of any stroke, epilepsies, hepatomegaly, splenomegaly, cataract, optic neuropathies, color blindness, frontal baldness, rashes, lipomas, or hearing difficulties. These things to be mentioned because all these carries differential diagnosis. When a patient is having sensory neural deafness, you can indirectly see the mitochondrial disorders. Hyperpigmentation can also be seen in Nelson syndrome, Addison's disease, and other skin changes like tightness of the skin pits are seen in sclerodermas. Scars or needle marks seen in intravenous substance abusers, and numerous dermatological manifestations of the neurocutaneous syndrome. As all of you know, neurocutaneous markers, these are the manifestation that involves both skin and central nervous system. We'll see later. This is a leprosy, tubercular type, well-defined, hypopigmented patch with slight scaling associated with the anesthetic patches. These can be macules or papules. As all of you know, Gattern sign, that is an erythematous scaly eruption over the extensor aspect of the metacarpal joint and digits. This is characteristically seen in dermatomyositis. These are the helictropia rashes. This is periorbital reddish purple color discoloration with slight elevation. This is also seen in dermatomyositis. By seeing the face, a patient presented with myopathy, and if you make out these helictropia rashes, so it would be easy to diagnose and treat the patient. Next. These are the Schall sign and V sign. The sun-exposed areas, patient will be having erythematous maculopapular rashes characteristically seen in the sun-exposed areas. This is called Schall sign and V sign. Mechanic hand, this is roughened, cracked skin at the tips and the lateral aspect of the fingers, resulting in irregular, dirty appearing lines. This is also seen in dermatomyositis. These are the capillary loop dilatation seen in the nail bed. This is also one of the important sign in the dermatomyositis. This is periangual erythemas. This is also one of the skin manifestations of dermatomyositis. By seeing these, you can make out the diagnosis. Let us come to the neurocutaneous markers. These are the neuro syndrome. Phenotypically and genetically involves multi-system, predominantly affect the skin and central nervous system. These are NF1, NF2, Leopard syndrome, tuberous sclerosis, ataxia telangiectasia, and incontinentia pigmenti. Let us come to the neurofibromatosis. These characteristically having the neurocutaneous markers of capillate lesion. There are the dark brown hypermelanotic macules with smooth or irregular borders, commonly seen on the back, buttocks, and the trunk. This can also be seen in McCune-Albright syndrome, Fanconi's anemia, and Bloom syndromes also. Axillary frecklings, there are similar small round spots which are characteristically seen in the axilla and inguinal areas. These are pathognomonic of neurofibromatosis. These are capillate lesions. Next. So one more capillate lesions and pigmented macules. This is plexiform neuroma. Next. The diagnostic criteria in a pre-pivotal age group, if a lesion size is more than 5 mm, and in a post-pivotal more than 1.5 centimeter. If patient is having lesion 6 or more than 6, this is indirectly indicate the neurofibromatosis. Next. Again, this is the capillate lesions. Next. This is the axillary freckling, that is axilla and groin region. Small macular rashes. Next. Neurofibromatosis are two types. One is fusiform and second one is plexiform. Fusiform, all of you know, like firm, discrete subcutaneous nodules which are present all over part of the body. These are confined to the nerve territories. In plexiform neurofibromatosis, these subcutaneous elastic tumors feels like bag of worms appearance, most commonly seen on face, scalp, and neck. These are the fusiform neurofibromas. This one is the plexiform neurofibroma. Next. Previously I told these are the least nodules. Most 90% of the patient of NF will be having these least nodules. Next. Adenoma sebecum. This is like better term would be the angiofibroma. These are the numerous discrete, smooth, glistening, round rubbery papules of pinhead size seen on the butterfly area of the face, nasolabial fold. These are slow growing angiofibromas. 90% of the patient of tuberous sclerosis will be having this kind of lesion by age of 4 years. A close differential diagnosis will be acne vulgaris. These are the adenoma sebaceum. This is a butterfly-like distribution. These lesions are nothing but angiofibromas. Involve the face, cheek, nasolabial folds, and the forehead also. This is one more diagram. plaques along with the adenoma septum. Next one is Sjogren patches. These are nothing but the connective tissue nevus, skin colored, irregular, lumpy cobblestone like plaques, predominantly seen on the lumbosacral area, which grows to the size of plum. Satellite papules grow slow around a central plaque with the orange peel-like indentation, seen in 70% of tuberous sclerosis patient. It can also be seen in MEN1 syndrome, Cowden syndrome, and Hunter syndrome also. These are the Sjogren patches, leathery plaques of subepidermal fibrosis, usually situated in the lumbosacral trunk. This is one more diagram. This cobblestone-like appearance, lumbosacral area with central plaque. And periangular and subungual fibromas, these are also characteristically seen in tuberous sclerosis. This also included in the diagnostic criteria of tuberous sclerosis. Most of the patients, they are telling 90% of the patient will be having tuberous sclerosis. One more diagram of subungual fibromas. Last one is hypomelanotic patches, that is Ashley macules. These are the polygonal hypomelanotic macules, grows up to 5 cm, predominantly seen on the trunk and buttocks, sometimes in the calf region also. More than 3 lesions are seen in 90% of the TS patient. This also be seen in MEN1, vitiligo, nevus, and Koyanagi syndrome also. This is the Ashley spots. These are hypopigmented macules, size around 1 to 3 centimeters, oval shape, polygonal shape, and lanceolate shape, whereas less common shapes are confetti-like lesions. Next slide. These are the discrete lesions. Confetti lesions are discrete lesions, multiple small. This is also called confetti macules. This is also Ashley spots. In woodlamp examination, you can see the Ashley spots circumscribed gray colored patches. In UV lamp also you can see. Next one is Potvin stain. That is congenital macular lesion. Light pink initially can progress to red purple nodules. Involves the skin, choroid, leptomeningeal vessels along the cranial nerves, predominantly seen in 5th cranial nerve distribution, classically defined in the Sturge-Weber syndrome. This is a Potvin sign involving the 5th nerve. Can anybody define this one? CT scan, any finding? Can anyone take?
Sir, Salmon patch appearance, sir.
This one, CT.
CT.
Hypertension signal, where you will see in CT?
Sir, hypertension bleed, sir.
Mm.
Bleed or fluid.
Fluid.
Sir,
Calcium.
angiomas, blood vessels, sir.
Calcium usually. Okay,
Okay.
calcification. This is called calcification. Tram track calcification. This is also called tram track sign. Unilateral, due to the, if patient is having, first, this sometimes involves a meninges also. Later part, it will calcify and it will calcification. Most of the patient will present with focal motor seizure or hemiparesis along with these nevus. Usually nevus side will be affected, opposite side will be focal motor seizures. This is a classical patient is having like these kind of nevus. If you're having a left focal motor seizure or left hemiparesis, that will indirectly indicate the Sturge-Weber syndrome that involving the meningeal vessels also. Okay, this is tram track appearance that is seen in Sturge-Weber syndrome. Next. Again, one more Sturge-Weber syndrome. This is involving the facial 5th nerve distribution, first and second divisions. That is causing facial hemihypertrophy due to this Potvin stain that is involving the blood vessels of V1, V2 distribution. Again, ocular telangiectasias. These are the dilated blood vessels which are seen over the sclera. You can see also on the nail beds and face also. It is seen after the development of ataxia, around 3 to 6 years of the age. If a young patient comes with ataxia, kindly examine for the telangiectasias also. Next. This is ocular telangiectasia. If a patient with ataxia presented with these kind of telangiectasia, you can directly make out the diagnosis. It is autosomal recessive cerebellar ataxia secondary to ATM gene mutations. Next. And cutaneous telangiectasia that involves the nasal bridge and butterfly area of the face, antecubital area, neck, popliteal fossa. In these areas also, you have to see whenever you are seeing the patient of ataxia, you need to see for these kind of vascular changes involving these mentioned areas. Seen in 90% of the patients by age of 5 to 6 years. This also be seen in Van Hippel-Lindau syndrome. This is the telangiectatic vessels involving the nasal bridge. Next. One more is incontinentia pigmentosa. This is an X-linked dominant disorder. Usually it involves the dermatomal distribution skin lesions. Patient will be having various stages, like initially you have the vesicle, then erythema changes. Patient will be having the seizures, mental retardation, and these kind of skin changes are neurocutaneous marker. By seeing this, you can make out the diagnosis. Next. This is again one more picture that is depicts in the involvement of lines of Blasco. That is development of dermatomal along the dermatomal distribution, skin dermatomes. And last one is spine. You need to see for the spine deformities, any abnormal posture and restriction of range of movements, localized tenderness, paraspinal muscle spasm. And most of this tuberculosis, brucellosis, neoplasm of the spine will causes maximum change in the curvature of the spine that causes the kyphosis. Called as gibbous. By examining this spine, you can make out the diagnosis. In case of muscular dystrophy, as all of you know, exaggerated lumbar lordosis, scoliosis also seen in syringomyelia, Friedreich's ataxia, and hereditary motor neuropathies also causes scoliosis. This examining these spine findings, you can make out the diagnosis. Next, localized rigidity with a slight scoliosis and absence of normal lordosis are frequent symptoms of lumbosacral radiculopathies. Tenderness to percussion over the spinous process using either fist or the reflex hammer. It can occur with a localized process such as spinal epidural hematoma, abscesses, local lesions causes tenderness whenever you are percussing the spine process. Then next one is spinal dysraphism. Spinal dysraphism is a broad term for the developmental anomalies that are involving the central nervous system. It consists myelocele, meningocele, lipocele. By seeing the sacral area or lower back area, if patient is having the hair, dermal pits or any tail-like appearance, you need to rule out in spinal cord deformity, developmental deformities. Next. Whenever you're seeing the hypertrichosis, dermal fits, pseudotails, lipomas, hemangiomas, aplasia, dermoid cyst on the back, kindly look for the spinal deformity. Kindly get the MRI lumbosacral spine done, because patient will be having underlying myelocele, meningocele defects. Next, last one is CV junction abnormalities. CV junction mainly constitute the occiput bone, atlas, axis, and supporting ligaments. It is the transition zone between the cranium and the spinal column. Next slide. Next. Okay, these are the structures which are underlying these bony structures: brainstem, lower cranial nerves, upper part of the spinal cord, cerebellum, and the tonsil. So whenever these craniovertebral junction abnormalities occur, like due to the lesion of this occiput bone, C1 or C2 vertebra, these will affect the lower cranial nerve structures, cerebellum, and upper spinal cord. Patient will present with lower nerve cranial palsies, spastic quadriparesis, UMN type of bladder symptoms, cerebellar ataxias, syncopes. Next. Classification. Just you remember the name. Sometimes examiner might ask, what are the types of CV junction abnormalities? Just you remember like occipitalization, basilar invagination, dysplasias of the dens or atlantoaxial dislocations, like flattening of the occipital base, dysplasias that is involving the occipital condyles, arnalgia malformation, syringomyelia, syringobulbia, all these come under the CV junction abnormalities. Just remember the names. Okay, next slide. As I told, the patient will be having pain, myelopathy changes, lower cranial palsies. Patient sometimes having recurrent episodes of the stroke even after treating with antiplatelet or anticoagulant due to the vertebrovascular insufficiency secondary to compression by the craniovertebral junction abnormalities. And cerebellar ataxias, due to the hydrocephalus, patient will be having raised ICT. Ataxia, atrophy of the upper limbs and syrinx carries worst prognosis. Last one, and that is one more CV junction abnormality, Klippel-Pill syndrome. As all of you know, patient will be having short stature, webbed neck, and decreased range of motion movements in the cervical spine, and patient will be having low hairline. Low hairline will be called if the hairline present below the C4 spine, that is called low hairline. Next slide. This is again type 1, type 2, type 3. These all things are not needed for you people. Just you remember what is Klippel-Pill syndrome. Okay, next slide. Here you see the patient. This is a low hairline is there, short neck is there, and vertebral column abnormalities are there, and patient is having short stature also. Okay, next. One more diagram. This is again low hairline, short neck, vertebral bodies abnormalities. Thank you. If any doubts, kindly ask me.
Sir, for cafe au lait spot, sir, if it is there, does it mean it's neurofibromatosis, or how is it like separate? Like only neurofibromatosis, how does it look? Or in other diseases, how does it look? How to differentiate?
Like capital lesions are same, but associated systemic symptoms. In McCune-Albright, patient will be having endocrinopathies. In von Hippel-Lindau syndrome, patient will be having cerebellar hemangiomas or polycythemias. Only associated symptoms you can make out. Capillate lesion in neurofibroma and other diseases, like it is by seeing you cannot make out. Any other questions?
No, sir. Thank you, sir.
Okay.
Next